Hello, hello. Okay, good morning. I just want to check. I believe the last time I had a class, the PPT did not show. Let me just check whether it will come up and then we'll continue. All right. So it seems to be working today. That's good. I'll just shut this off. Just hang on a sec. Hello? Okay, thank you. Right, so continuing where we left off, we were talking about the large intestine. And we said it starts at the cecum and appendix, continues as the ascending colon, then there is a hepatic flexure, then there's a transverse colon, there is a splenic flexure, there's a descending colon, and it continues as the sigmoid and the rectum to open at the anus to deliver the contents or the after effects of digestion process to the external environment. Now rectum and anus will come after. Actually, sigmoid we could have discussed in the last class itself, but it's a significant area from the point of view of surgical importance, so we are giving it a little more time. It won't take 45 minutes, so I'll leave you early. I hope in the meantime, since you were not able to see any visuals in the last class, I hope you'll have had the common sense, the good sense, to look it up in a book and an atlas and revise it in a textbook so that all the points are clear. What is the large intestine? Where is it? What are its features, its morphology, its supplies, and its applied anatomy? So let's continue with the sigmoid colon. Right. So this side's shown you also in the last class, and it's probably useful in case some people missed the class or did not do any reading on their own. So we have the beginning of the large intestine, where the ileum ends at the ileocolic junction or the ileocecal junction, and then you have its big dilated sac-like beginning called the cecum. I think you had a class on it yesterday or some recently, and it has a small finger-like, process-like diverticulum, which actually was part of the original hindgut, but or rather midgut. But here it has only retained its fetal proportions, which is why it did not grow into the dimensions of the adult colon. But it matured in terms of histology into the adult structure, but not in terms of its morphology, of its dimensions. So therefore it has a different look and a different function. The jury is still out on why it happens that the appendix is there. Periodically the opinion about how useful it is, whether it is sacrificable or not, because it is a source of repeated inflammation. All that happens. I'm sure you had a class on that, so I won't spend any time. But after cecum and appendix, you had the ascending colon, the flexures, the transverse, another flexure, and the descending colon in the last class. Now we are coming to this S-shaped loop here, which is called the sigmoid colon. The name is after the Greek word sigmoid. And this again becomes a intraperitoneal loop of gut after the transverse colon. So there is a fixed part, which is retroperitoneal, and then again there is an intraperitoneal, very mobile part. So mobile that most of the time it's not even here in the left iliac fossa, but it is in the hypogastrium, in the area of the bladder and the uterus in females. Those loops are loose because of the mesentery. That mesentery is called the sigmoid mesocolon, and it can be variably loose or tight, in the sense its width can be quite long, which makes the sigmoid very mobile, or it can be quite short, which could keep the sigmoid a little tight. Now, as we saw, the dimensions of the intestine have been decreasing as we go, simply because the volume it contains has been decreasing. So descending colon is narrower than ascending colon, and sigmoid will be even narrower. It's a narrower tube. It will have the same features, however, as any other part of the gut. So if you look at it just in an open abdomen cavity, You won't see it at all. Are you seeing a shadowed line here? So this is the rectum, and this part is the sigmoid, which means it's lying behind the loops of small intestine. The light pink is small intestine, the brownish is large intestine, and this large intestine, which is retroperitoneal, is continuing as sigmoid. So it could be somewhat short and somewhat tight depending on the looseness or the freeness of the sigmoid mesocolon. The rest of it, like I mentioned in the last class, we had these gaps between the body wall and the gut called the paracolic gutters on the right and left side, and we had the remaining parts of the intestine. This is just to show you that it is, though it is loops and though they are free, they are always behind the small intestine loops. They are posteriorly placed and deeply placed, and most often, especially in standing position of the individual, they'll be falling into the pelvis. They won't even be above the level of the inward. They won't even be palpable or visible above on from the soft abdominal wall. They'll be in the protection of the pelvis very often. And depending on the posture of the patient lies down, the loops may rise up a little bit. So all this will make a difference to how you interpret a patient's symptoms they come to you. If they say pain abdomen, acute pain, and disturbances in defecation in the rhythm, that is the cyclical voiding of feces, or in the nature or the formation or the type of stool that they are passing, depending on all of that, we get the clues on which part of the bowel is this patient being troubled by. So for that, we know already that the large intestine functions are, it absorbs all the remaining nutrient, whatever little bit is there in small molecular format. Because there are no villi and there is no specialized absorption apparatus, there is only the simple microvilli on the surface. So you have the mostly water and electrolytes being digested. It forms, stores, and expels. Forms in the sense there's no manufacturing process. Whatever is left behind after all the absorption is over is feces. It is stored. Now, by this time, peristalsis becomes much more sluggish and slow. Propulsion is weak, except for mass peristaltic movements. I'm hoping that at this time, parallelly, physiology is taking digestive physiology. So you realize that there are three different types of movements of the propulsion of the gut contents, right from mouth, from swallowing to anal action. And the main peristaltic wave is very active and very vital, dynamic in the upper parts of the gut, in the small intestine, but becomes somewhat slow, attenuated by the time it comes to the large bowel, and particularly the end of the large bowel, which is the sigmoid colon. So please correlate with physiology and with biochemistry as we take the anatomy classes for you. So I'm just spending a little more time on the functions. So we have the haustral churning. We said that, okay, we'll go down a bit. Yeah, so we said that the sigmoid colon, or rather the entire colon, has this structure of having 3 tinea coli and haustrations and saculations and appendices epiploic. I'll come back to that in a second. Alright, so we have mechanical digestion, which is the function of the whole large intestine, starting from cecum right up to the rectum and anus. So, and you have peristalsis, and you have some reflexes called the gastroileal and the gastrocolic reflexes. The minute you put some food into the stomach, the colon has a response to it, though they are not nowhere near each other, they are meters apart, but that's because of the reflex action set off by the distension of the stomach. That itself sets off certain reactions or responses way down the gut. This is very clearly seen in small babies. If any of you have ever had to take care of a little one, you'll see that almost immediately as soon as they have a milk feed, they will have a purge. They will have a bowel movement, little babies. So that is because of this gastrocolic reflex. Now, as we grow older, that immediate translation is not automatic. The colic reflex still exists, but we do not defecate because we have much better control over our sphincters. So the point remains that there's a physiological connection, and you must correlate that as we study the anatomy. The chemical digestion we already know is secretion of the enzymes, but in the colon there are no enzymes. There is only absorption of water and electrolytes. Bacterial digestion is an extra thing which has been added within the movements of the colon, where there is a fermentation of the carbohydrates. As they are waiting, they're just sitting there. If there are any carbohydrates there, they will be acted upon by the local flora, which means the commensals, the symbiotic microorganisms which inhabit our gut. And there will also be some amount of protein and amino acid breakdown if food has arrived there without being completely broken down in the small intestine, ileum, and completely acted upon by succus entericus and completely absorbed by the villi and microvilli of the small intestine. Whatever is remaining behind comes into cecum and ascending colon, transverse colon, and is very, very, very slowly moved. Therefore, there is enough time for bacterial digestion and for breakdown of remaining materials. And some of that ends in the formation of gases, which end up being a so-called digestive gases, which pass out of the individuals as flatus. So there is feces and flatus, and that formation is happening in the large intestine. Absorption, like I said, water and particularly vitamins B and K. K because they're being formed there by the action of the flora. And the concentration and the elimination of the waste. So whatever is remaining behind cannot be utilized by the body. In fact, if it stays there too long, it's toxic to the body. And that's one of the reasons why it ends up being a vulnerability, it ends up being a risk factor if there is too much of stasis in the large intestine, and particularly in the sigmoid, we get to see the effect of years and years of stasis of food products which have undergone bacterial digestion and breakdown, and therefore they have become, some of their byproducts are toxic and precancerous, and therefore can lead to a stimulation of the mucosa. We have a mucosal lining, right? Simple tall columnar epithelium with lots of goblet cells, if you remember. Now that epithelium can, because it's anyway undergoing mitosis, it's a high turnover epithelium. Some of those precancerous things can stimulate a mistaken cell division, which would become a mutation, which would give rise to a cancer. So the sigmoid colon is a site for high incidence of colonic cancer, and that's what we have to keep in mind. And that's because of all the factors related to its function, and especially to the kinds of diet that people eat, that you will learn in community health and again next year in pathology. But the segment of population which would most likely have colonic cancer will be determined by their daily habits and their dietary habits. We'll see that as you come into the clinical questions. But right now, just remember that this is what their functions are. Chyme is the whole semi-solid mass which has entered into your digestive tract, and it's getting more and more dehydrated to form the feces inside the large intestine. And that feces at the end ends up being composed mostly of water, a few of byproducts of digestion, whatever is left. For example, human Homo sapiens cannot digest cellulose, right? Whereas cud chewing animals, cows, goats, sheep can. So since we do not have the enzymes to digest cellulose, anything which is fibrous in our diet will come out as it is. It will enter the intestine without being broken down. So things like that. So we can't really call it, we can't call it end products of digestion, because end products will actually get absorbed. The byproducts, which actually don't get acted upon, will become the components or the constituents of feces. And we'll have some inorganic salts, a lot of epithelial cells. So these meters and meters of gut that you have, the surface is continuously being abraded by the stuff which is moving through it. So some cells will shed. If you remember, we saw at the bottom of the villi and of the intestinal glands, there would be basal cells or pluripotent cells which keep on dividing and supplying and keeping that mucosal lining complete and intact at all times. But from the surface of the villi and any projections, some cells will be shed off by simple attrition, by rubbing with external material. So a lot of epithelial cells will be there in our feces, and bacteria themselves, which anyway live in our gut, a few of them will get washed off with every motion that is passed. So in defecation, peristalsis pushes this feces into the rectum. The rectal wall stretch, and then there is an action. We'll study that with rectum and anal colon. But remember that all of this is already happening by the time you come to sigmoid colon, and the control of it is under parasympathetic control, which we had, if you remember, we said inferior hypogastric plexus, it is the S2, S3, S4 segments of the spinal segments, not vertebral segments, spinal cord segments, which are somewhere near L1 level. And there is a voluntary sphincter which we learned with anus. So there is an internal involuntary and an external voluntary sphincter, which will allow us to hold or open and release the contents of the rectum. That comes later. As far as sigmoid is concerned, all of this is still part of it, though defecation is almost entirely correctly, the process is only done by rectum and anus. So on the outside we said there are tinea, which is the longitudinal muscle fibers which do not form a continuous layer. I do not have the picture here, I'm sorry. This is the next one. Tinea are not present in the rectum and the appendix, where we didn't see that, but definitely present in our sigmoid colon. Then you have the appendices epiploicae, which are fat-filled protrusions of the serosa scattered over the surface of the large intestine. They were not there on the cecum. Actually, they were there, but they're not well formed. So it looks like one single sac without very clear tinea. When you open the abdomen, when you look at it in the practicals, you'll notice a difference. The cecal tinea are not so well pronounced as the remaining colon, but sigmoid colon tinea are pretty much well pronounced, and the haustri and the haustrations or the saculations are also pretty much well pronounced. Semilunar folds, if you open up and see the inside of the mucosa with your naked eye, not under the microscope, then you will see semilunar folds of mucosa, and they are functional features because their depth or the length of the fold will change with the muscular contractions of the wall, and they correspond to the external. Between haustra there is a dip, and then there is a bulge and a dip, right? So that dip is what corresponds to the semilunar fold inside. I think I showed you in the last PPT. I don't have that picture here, but just remember that semilunar fold is an internal feature. Tinea, epiploices, and haustria are external features, same like they are in the remaining large intestine. So these are the external features. We already talked about that. We're not looking at the rectum today. We're only looking at the sigmoid colon. Now the mesentery of this is called the sigmoid mesocolon, and this picture was there in the last class. But basically, we are talking about that part of the large gut apart from the transverse colon, which has a mesentery. So when these intraperitoneal parts of gut were being hung down by mesentery, the last thing was the small bowel mesentery, where you had the ileum. After that you had a transverse mesocolon, actually before that, but if you're following the passage of the food, this comes after. But if you're following the folds of the parietal peritoneum jutting forward to become a double sheet of visceral peritoneum, then transverse mesocolon is higher attached, then comes mesentery, and then comes sigmoid mesocolon, which is higher lower meaning superior, middle, and then inferiorly attached. So you have a mesosigmoid, it's called, from which is hanging the sigmoid mesocolon. I mean, this is not there on the right side, it's more on the left side, but this is a midline section, the diagram of a hemisection, sagittal section. So it is there, it comes almost up to the midline, but doesn't go on to the right side of the body. So you have the loop of sigmoid hanging down from it. So this is what the sigmoid mesocolon will look like. I don't know if they have labeled it. Okay, no. Okay, this is one picture which I could get. It's not a very good picture, but that if you look at the sigmoid mesocolon, it will have a V-shaped attachment. Okay, so descending colon will stop somewhere here, and from here where the sigmoid starts, it's becoming intraperitoneal. So from this edge to this edge will be a fan-shaped mesentery called the sigmoid mesocolon, and its attachment on the posterior abdominal wall will also be an inverted V-shaped, and the apex of the V will be lying on the left ureter. We'll come to kidney and ureters later, but what you need to remember is that the entire digestive tract is anteriorly placed and attached compared to the urinary tract, right? So anything which is suspending the intraperitoneal parts of the digestive tract, its attachment when it goes, the sigmoid is hanging here. Covering it, the sigmoid mesocolon goes back to the posterior abdominal wall and then becomes a parietal peritoneum. That attachment from into which the blood vessels, lymphatics, nerves have entered is in the form of a V, and the apex of the V is on the left ureter. So you should have a left kidney here, left kidney and a right kidney here. So the left ureter will be coming down here, and it is trying to go to the bladder, and the bladder is anterior to this rectum. So when the ureter is trying to go to the bladder, where it is crossing the posterior abdominal wall, this transverse mesocolon is on it, is related to it, and it becomes a very important surgical relation, which we will come to in a minute. So I am sorry I'm not able to show you another picture of the transverse mesocolon. Please look for it in your atlases and your textbooks. Not transverse, sigmoid mesocolon, and look for how it is reflected off the posterior abdominal wall. Then let's come to the supplies. So you have this loose loop of gut, right? Now in this picture, we've kind of moved it off the posterior abdominal wall and pinned it up and hung it out like this to show the continuity between cecum, ascending, transverse, and descending, and sigmoid. But actually in the body, at this point, till this point, it is clustered to the posterior abdominal wall and retroperitoneal, and suddenly becomes intraperitoneal because this sheet, this light orange yellowish sheet, is the sigmoid mesocolon, which is bringing the vessels to it. So which vessel are we talking about? The inferior mesenteric artery and its branches. So this is budding off. This is a superior mesenteric. It has been given off from abdominal aorta higher up, but after the duodenum and ileum, where the duodenum becomes the intraperitoneal jejunum, at about an inch below that, about 2 to 3 centimeters below that, from the anterior midline of the aorta comes out the single unpaired ventral branch of the abdominal aorta called the inferior mesenteric artery. It has a short course, and then it starts giving off its left colic vessels to the descending colon. And this descending colon, you remember, was going to be having an arterial anastomosis with the transverse colon at the left splenic flexure, which is that arterial anastomosis was called the arc of Riolan. I did mention in the last class. So that is the first branch of the inferior mesenteric, and then you have further left colic vessels, and then you have the sigmoid vessels. They're usually 2 or 3 in number. They're called the sigmoid arteries, branches of the inferior mesenteric. And the last one of them will be the superior rectal artery going to the topmost part of the rectum. So this would be superior rectum, and this would be the last of the sigmoid branches. The sigmoid branches will give short penetrating vessels into the gut wall and form arc-like anastomosis with each other, exactly like the earlier pattern which we talked about, which was called the marginal artery of Drummond. So if you put all these same caliber vessels together all across the whole length of the large intestine, that's called the marginal. It's not a singular artery from a singular source. It is a almost uniform caliber arterial anastomosis along the internal or inner margin, vascular margin of the entire digestive tract. So these sigmoid arteries are forming some short, some longer vessels which penetrate the sigmoid wall and supply. Similarly, you will have a venous pattern. Good to see here that you have a left kidney and you have a ureter, the white one, right? And where it is coming from lateral to medial, coming towards the urinary bladder. The bladder is somewhere here. So where it's coming towards urinary bladder will be the root of this mesentery, into which these vessels are going to be entering. Now here the vessels are looking as if they are all on the same plane. They are not. Please remember, the left colic vessels, 1, 2, or how many ever of them, will be retroperitoneal, will be going flat across the posterior abdomen behind the parietal peritoneum, whereas the sigmoid vessels will be entering at somewhere here into the double sheet of sigmoid mesocolon to come towards the loosely hanging part of the gut. So that is not clear unless you actually see it at a dissection or at a surgery. I will show you when you get back. So the vein correspondingly is the sigmoid veins, the last of which is the superior rectal vein, which is very important in hemorrhoids and in portocaval anastomosis. We won't look at that right now. You look at it again in your class on rectum, maybe tomorrow. And now we'll only look at the tributaries to inferior mesenteric vein, which are simply called sigmoid veins. There are plenty of that, and they will form the inferior mesenteric vein, which, if you remember, goes and becomes a tributary to the splenic vein. before that joins the portal system. So all your vitamins and your water and your electrolytes and whatever else has been absorbed from here will go back to the liver first. So we have the sigmoid veins, tributaries to inferior mesenteric veins. This is the vascular distribution for sigmoid colon. What about the nerve supply? So a little bit of a cartoon. I don't know if you can figure it out. So the distension of the submucosa happens with the submucosal plexus, which stimulates transmission of nerve signals to smooth muscle. So when material, semi-solid material, enters into the colon, any part of the colon, this applies to any part of the colon, but we are talking about it with sigmoid, is that the afferent signal is distension of the gut. It's a visceral sensation, right? And that stimulates the motor, visceromotor fibers, which ask the smooth muscle to contract and empty. And this initiates a peristalsis, and there will be mixing contractions. There is a lot of stasis, remember, so there will be a lot of mixing contractions before it is allowed to void out. For there will be quite some time when it is kept together. So stimulation of the vagus nerve for most of the intestine, but for descending colon and rectum, it is the sacral spinal nerves which I was mentioning. So the pelvic splanchnic nerves, they increase the gut and sphincter tone, increases the frequency, strength and velocity of the smooth muscle contractions, as well as motor secretory activities, if any. In this case, there is only goblet cells, not much. There's mucin secretion, important to keep this peristalsis going. But remember that parasympathetic increases the gut tone and the sphincter tone and increases the frequency, strength and velocity of smooth muscle contractions, as well as secretomotor activity. Whereas stimulation of the sympathetic reduces the paralysis and reduces the GI activity. It's supposed to be a piece of gut having a nap, but we know this. This is rest and digest, and this is fight or flight. So when you're fighting or flying, the blood supply and all the focus of the body systems must be towards your muscles and your cardiorespiratory system and your brain, right? Not towards your digestive tract. So sympathetic drive will reduce peristalsis and digestion. Parasympathetic drive will increase peristalsis and digestion. We already know this. Is just a interlude to remind you of what is going on by the time products of digestion enter the sigmoid colon. Now let's come to applied aspects. The sigmoid is an area, like I mentioned, of high incidence of frequency of cancer. In different parts of the world, the percentages of this cancer vary. In Asia, Southeast Asia, and our subcontinent, comparatively there is less. But in the affluent socioeconomic group, the richer, better educated, more urbanized patients, there is an increase in catching up high incidence of colon cancer. In westernized societies, the so-called first world, it has been there for many decades now, and the way the surgery has evolved has already become very sophisticated, giving them good long-term survival and a good quality of life also. But the solutions are a little drastic. Let us look at how it goes. So the patients may come to you with a diverticular disease, which I mentioned in the last class, for which we mostly do a medical management. Like I had mentioned, the patient may not even know he's a patient. You and I may have diverticulosis and never be bothered by it, and we won't even realize unless somebody does an autopsy on us or we end up on a dissection table because we've donated our dead bodies. And then the students discover, oh, there is something called diverticuli in this person's large intestine, including the sigmoid colon. If at all those diverticuli get inflamed, then we call it a diverticulitis, and we do some medical management. We give some antibiotics, we give some anti-inflammatory drugs. You learn all about that next year with pharmacology and pathology. But that is easily or conveniently managed medically to a large extent. When these diverticuli are in the sigmoid location, and especially if they get inflamed, the frequency of complications is very high, and therefore we may have to go for a surgical solution. Let me come back to this later. We finish the first point. Bowel obstruction, on the other hand, is a frequent way for the patient to land up in an outpatient and seek medical help. And if that bowel obstruction is of small intestine, you would have done it with classes on ileum jejunum. What happens? It could be so many reasons, but if it's a large bowel obstruction, especially in this location, the most frequent cause is a tumor. And the tumor would have been missed over a long period of time. It has grown, and suddenly it has caused an obstruction which leads to backup and therefore the symptoms of the patient. But a large bowel obstruction can also happen due to hernia. Now, there were lots of little peritoneal recesses along with the duodenum and jejunum. There aren't so many in the greater sac. But still, wherever retroperitoneal becomes intraperitoneal and intraperitoneal becomes retroperitoneal are areas where the peritoneum will raise a fold for the mesentery to come up, and that could become a small area where hernia is is pushing. Diverticulitis itself may also cause a bowel obstruction. The gut completely shuts down. The peristalsis shuts down because of the irritation and the inflammation, and therefore it is a physiological or a muscular obstruction, not a physical obstruction on top because of a pressure on a loop or an intraluminal obstruction, but simply that the physiology has stopped. So that could lead to an obstruction. If it is an acute abdomen presentation, acute pain, very distressed, patient is collapsing, and because there are reactions to when the gut shuts down, there will be a lot of fluid secretion pouring into the peritoneal cavity. Lots of things will happen. This acute abdomen presentation sometimes requires an urgent or emergency surgery. So coming back to diverticular disease, particularly in the sigmoid location, a surgical resolution is definitely sought if there are going to be complications of this, which include a pelvic abscess. This inflammation may not be due to diverticulitis, but this is an area in my time, in earlier generations, amoebiasis was very frequent. You may not get to see too much of it. In urban practice, people are usually a little more careful with their food, and they may not have picked up a lot of amoeba. But even if they have, they may not. It may not go to an amoebic abscess level. For that, usually the patient's general immunity and nourishment stage, nutrition status is low for an abscess to develop. So, if there is an abscess in the sigmoid region, like I told you, mostly in the standing in the erect posture, the loops are inside the pelvis, so it can cause a pelvic abscess situation, and the symptoms will be relative to pelvic abscess. If that pus formation bursts, then it can soil the peritoneum, pelvic peritoneum, and give rise to problems, and we must deal with it surgically. Like I said, because the sigmoid mesocolon crosses the left ureter, any inflammation of the mesocolon or any vascular insult or any diverticular disease inflaming the posterior peritoneum can give rise to a left ureteric obstruction. The ureter's got nothing to do with sigmoid colon in terms of function, but anatomically related, and therefore you can have a left ureteric obstruction secondary to a sigmoid complication. If this is not if the loop of sigmoid colon, which is in the pelvis and inflamed, is rubbing against the urinary bladder wall, which it is related to. The urinary bladder is infraperitoneal, we'll look at that later, but its superior surface is covered with parietal peritoneum. There is a possibility that inflammation of the wall of the sigmoid colon would raise a peritoneal inflammation, which would become a bladder wall inflammation because they are continuously in touch with the other for a long time. And the inflammatory process could bore through and cause a fistula between a sigmoid colon and a urinary bladder wall. So a feco-urinary fistula can happen, right? Colonocystic, cystocolonic fistula, things like that can happen, and that definitely requires a surgical treatment. So just remember that because of the sigmoid mobility, because of the stasis of food inside and the likelihood of so many complications of the stasis, because of the possibility of a diverticulosis, which is a reasonably common phenomenon, which can become a diverticulitis, as a consequence of which there could be a sigmoiditis, which would then impinge on anything which it touches, because it's a mobile piece of gut. Whatever it touches can create a problem. So if it's in the pelvic wall, it can create a pelvic abscess. If it's rubbing on the bladder, it can create a bladder inflammation. Without doing anything, just because the mesocolon is related to the ureter, it can cause a ureteric obstruction. So remember that sigmoid becomes an area where different kinds of pathologies can happen as a consequence of something starting in the sigmoid. So what do we do when the patient comes to us with these complaints, right? How do we get any information about sigmoid as such, especially if we have to first suspect it, looking at the location of the pain, looking at the history, looking at, if you take a detailed history of diet, what happened, how did it start, and everything about the patient. And you confirm your suspicion with a radiographic investigation called a double contrast barium enema. I found only one picture of it. I'll show it to you in the next slide. Nowadays, the procedure of choice, if the patient is not moribund, is not too sick, and is able to tolerate a sigmoidoscopy or endoscopy, then we introduce a scope per rectum, and we are actually able to visualize through a flexible fiber optic endoscope the inside mucosa of the sigmoid colon. Immediately we'll get an idea of what is happening and what is causing this person's problem. So this is what a double contrast looks like. Double because you're using a radio opaque dye such as barium sulfate, and you're doing air insufflation. So then the dye gets pushed against the wall and only outlines the wall features, and the air fills the lumen, so you get to see what is happening. Is something protruding into the lumen, or is something budding out? Can you see these small little round things? These are the polyps which are growing out from the wall, right? These are the normal hostrations, of the colon, and this whole bunch of round ended features which are never there in a normal gut, and these would be the colorectal polyps. So usually this phenomena, this is not diverticulosis. This is a different thing where you have these round projections from the mucosa. So this is a mucosa, and it's projecting from the mucosa, and it is a mushroom-like bump. It may or may not have a pedicle. It may be directly, bulging out from the mucosa. So mostly they are benign and asymptomatic, but they can bleed if there is a hard bowel movement. And this one has grown quite a lot. The mucosa may get abraded and a little bleeding may happen. And they are known to be precancerous. So you can have a benign polyp for years and decades and decades and decades, which might turn cancerous in the old age, especially 60, 65 plus is where most cancers start developing, even in benign preconditions. So you have bowel obstruction as a presentation, which could be because of a tumor or a hernia or a diverticulitis. You have diverticular disease in itself, which is mostly managed medically. In the sigmoid, you have to think of the complications possible. And there is a third thing called polyp formation, which is not diverticulate, which is polyp. The difference is the polyp is protruding, it's a solid mass protruding into the lumen, whereas a diverticulum will be a pocket dipping out of the lumen, and that'll look different. This is a polyposis picture. Please look up. I think your textbooks also have, and your illustrated atlases will also have pictures of a diverticulosis. Now, if it is a osis, it's not a itis, it is just diverticulae are there, it is safe to do a radiography, double contrast or anything. But if it's already inflamed, the patient is already very sick and in pain, you do not subject them to an investigation which will be more painful. You can't even do an endoscopy when it is very acutely inflamed. So you manage them, control it for some time, and then you do the investigation to confirm your suspicious diagnosis. So the surgical aspect is, what can we do if the decision is there's nothing much we can do now, we have to take out that loop which is causing the trouble. The vessel pattern and the lymphatics will determine the extent. So the lymphatics are the nodes which are located at the inferior mesenteric artery. So sigmoid lymphatics will drain to the inferior mesenteric lymph nodes. The vessel pattern for sigmoid colon will be the lower left colic vessels and the sigmoid vessels. They'll have to be tied Then the loop will have to be cut between ties at the two ends, at the ending of the descending colon and the beginning of the rectum. The two ends of the digestive tract will have to be sealed off with sutures. Then this cut off loop with its vessels with a bit of sigmoid mesocolon will have to be excised and removed. That would be a sigmoid colectomy. If there is only diverticular disease and you want to do a partial or a segment resection, not a full colon, but then a local resection is what you're attempting, 1 inch, 2 inches, whatever it may be, then you must be very careful to choose only those vessels which are supplying that little bit of gut and not cut off everything else, because then the remaining things which you leave behind will die of ischemia. So it's a sophisticated, careful surgery that we need to do. But we are lucky that we have so much, not excess, but so much alternative blood supply available to these loops of bowel. So whatever we leave behind, if you do a small localized incision, the bit that you take out is short, and the segments on both sides are still mobile because they're still part of the sigmoid. You can do an end-to-end anastomosis of the gut. So you take out a small bit, and the healthy bit to healthy bit, you stitch them back layer by layer, right? Mucosal layer, muscle layer, serosal layer separately. Make sure that the remaining portion is viable. That means blood is flowing to it and it is well supplied. Its arteries, its veins have to be kept behind. As far as possible, the nerves should not be disturbed. So this thing is done, and then that little bit of resected bowel will be sent off for biopsy to confirm that you have taken out the lesion completely and it is what you suspected it to be. So this is what is done in a more localized excision. If you do a full sigmoid colectomy, you're stopping at the inferior end of the descending colon, and the next restart is at the rectum. Obviously, food will not be able to move down. There's too much of distance, and both of them are extraperitoneal structure. They are fixed, rectum and descending colon. So you can't mobilize them and stitch them up to each other, or nearly impossible to do. They are in too far off places. So nothing will enter the rectum, but this patient has to be kept alive after all this. You've done a life-saving surgery. So we do what is called a colostomy, right? So if we are going to be removing the entire sigmoid to save the patient's life from the cancer that he has acquired, depending on the staging and the size and so on of the cancer, then that last bit of descending colon, we mobilize it and you stitch up its open end to the anterior abdominal wall, leaving an os, a mouth, through which the products of digestion can be emptied to the external world. There we attach a sealed bag, a plastic bag, to collect the contents, that is the feces actually, and that is periodically changed and removed, and there is a procedure to toilet it, to seal it and to keep it very clean and very sterile. It will be attached on the anterior abdominal wall. You wear your clothes on top of it and you can have a normal life. That's actually the state of the surgical sophistication that we've reached. So in a colostomy, many times it is done to protect the distal bowel after the surgery. That means the large bowel obstruction has come to you as an emergency and is likely to perforate at any minute, and the patient is too sick and the bowel is too sick for us to do anything about it. So we just go to a proximal healthy segment and do a colostomy with it, so that the food will not go further down into the disturbed segment and can be removed from the outside, allowing this inflamed bit to be attended to be healed, to be treated, whatever it may be. And once the whole disease process settles down a bit, we can close the colostomy, we can return it back. It can be a temporary procedure, a temporary bypass procedure, which is called a defunctioning colostomy. You are allowing the sick part to rest, to not do any function, right? Remove the function from that part. But sometimes, like I described before, you have to when you do a full resection, you need to do an end colostomy, which I was talking about. When, for example, if there's an excision of rectum and anus because of rectal carcinoma, which is also very, very frequent, then obviously the sigmoid colon is a mobile loop, but there is no way to bring it up to create any exit point at the perineum, right, where the original anus was. So we do a colostomy to the anterior abdominal wall from the end of the sigmoid colon. The first example was from the end of the descending colon. Now it is from the end of the sigmoid. The descending is there, the sigmoid is there, the rectum anus are not there. So the end of sigmoid, we do an end colostomy to the anterior abdominal wall. So like I said, we fix the collecting bag. We teach the patient and the patient's attendants, family members, wife, husband, whoever it is, how to take care of this os. This management is tolerated pretty well. In fact, in many parts of the Western world, they have what is called colostomy clubs, where all these patients who are living with a colostomy, uh, they form a kind of a mutual self-help group where they share their experiences and their best practices and support each other, and they live useful, productive, reasonably normal lives. So that's where we are at. New procedures, new kinds of surgeries are being invented all the time to try to make the trauma to the patient minimal, to try to give them as normal a life back as possible, and most primarily to give them the longest possible survival possibility. That depends on the sophistication of our pathology grading, the speed with which we can diagnose what is wrong. So the diagnostic techniques have become more sophisticated, the pathologic techniques have become better, the surgical techniques have become better, and your generation hopefully will come up with some very, very brilliant solutions. The best of which, of course, would be to prevent colon carcinoma altogether, which will not be any of these specialities but will be a public health, nutrition, community medicine breakthrough if we can get people to change their diets in such a way that they don't get cancer in the first place. Okay, so that's enough for today. I think we've crossed our time. I'll catch up with you with the next topic on Saturday. Have a good day ahead.